All right. Good morning, everybody.
Morning.
Good morning.
Good morning.
All right. So we have everybody here. Let's see. I think we still are waiting on one or two people, so we'll just give it a second.
Grace is on vacation, Dr. Pass, so she won't be joining.
Really? I thought well, you know, the outstanding fellows, they come on vacation.
So,
Well, let's see here. Then we have David, and I guess Tarek is here, right? So then I guess we're good. Let's just go right ahead then. Okay. So some more questions today. So this is a 6-year-old child presents after cardiac arrest. An electrocardiogram obtained after he's made a full recovery showed the findings that we're looking at in these tracings below. What would you think is the most appropriate therapy? A, implant an ICD. B, begin beta blocker therapy and follow up in 2 weeks. C, perform an electrophysiology study. D, start amiodarone. And E, implant a pacemaker. So why don't we ask Dr. Bonsall, what do you think is going on here?
sorry. So, I mean, clearly the QTC is prolonged here, and we have an episode of sudden cardiac arrest, so implant an ICD.
I think that's correct, but let's go through the other choices. So begin beta blocker and follow up in 2 weeks. What do you think about that answer?
If the patient would not have presented, like if I saw it otherwise, if it was caught otherwise that the QT is prolonged, then I would start beta blocker and then follow up.
Go ahead. I'm sorry for interrupting. I apologize.
No, go ahead.
I was just going to ask, so you're going to implant an ICD. Would you start a beta blocker also, or is an ICD good enough? What are your thoughts on that?
Yeah, I mean, typically I've seen you put an ICD and also start beta blocker.
Yeah. Now, why is that? Why would crazy Rob do that?
Not crazy. Beta blocker itself does not affect your QT, but that is the only thing that has been known to prevent sudden cardiac arrest.
That's right. It's certainly well, it's the only one to prevent arrest, and it definitely has been definitively shown to reduce the statistical likelihood of arresting in long QT syndrome. The only debate in regards to this statement is in the setting of which long QT type is it thought that beta blockers may be a little less, potentially less beneficial?
QT3, long QT3.
That's right. So in long QT type 3, which is what kind of a channelopathy?
I get confused, but it is with the prolonged action potential.
Right. So it's either sodium or potassium. So what do you think?
Yeah. Potassium.
Good guess, but wrong. Don't buy a lottery ticket today. So no, it's a sodium channel blocker, or a sodium channelopathy, I should say. And you know, it's generally speaking, on average, people with long QT type 3 have longer QT intervals and more severe clinical courses. And there are entire papers on how to manage them. And that's the one long QT type where there is still some debate regarding the benefit of beta blockade in those patients. I think it would be fair to say that the majority of cardiologists would start a beta blocker. You might consider starting propranolol as opposed to natalol, though, in a patient who had long QT type 3, because propranolol does have weak sodium channel blocking effects as well. Okay. And in this case, there's different, if you ever read any articles, general articles about long QT syndrome, you'll see that there are, it's believed that there are certain morphologies to the T wave and the ST segment that are more typical in different forms of long QT syndrome. This type with this very long isoelectric period, as we see in panel C here, would classically be considered to be consistent with long QT type 3. And it may be that part of the reason they've put beta blocker therapy in there as a possible choice is because this would be a case where you might not consider beta blockers. Although, again, I want to be very clear, 99% of cardiologists would start a beta blocker to a patient like this, especially this early on, because we would not have genetic testing results back for 4 to 6 weeks usually. So you would certainly need to do something to prevent sudden death. What about perform an EP study? Any utility to that?
No, I don't see any utility to that.
That is correct. What about starting amiodarone? That's a good anti-arrhythmia medicine, and the patient just had a very serious arrhythmia.
I mean, it does not help in QT, long QT syndrome, and then again in type 3, it should not be given.
What about in type 1 or 2 or 4 or 5, 6, 7, 8?
I mean, it should
12,
not be given, but it's like specifically contraindicated.
Why is that, though?
Because it also affects it also prolongs the action potential.
That's right. That's in fact how it works. That's one of the mechanisms by which amiodarone works, is by prolonging the action potential. One of the interesting things about long QT syndrome is, a little bit of QT prolongation actually reduces the chance of having ventricular arrhythmia. And that's how some agents work. Sotalol does that. Amiodarone does that. So a little is good, a lot is not good. And one of the interesting things is, in the old days, when we would put an ICD in somebody, we would often do what's called a defibrillation threshold, where we would induce VF and then see if the device was able to both sense the arrhythmia and shock the patient out. And we still do that occasionally for various reasons. But it has always been known that in long QT syndrome, it can be very, very challenging to induce ventricular tachycardia in the cath lab, which is not obviously intuitive, right? Because you would think somebody who came in with a cardiac arrest who has long QT and is at a very high risk for another arrest episode would be very, very easy to induce. But in fact, you can sit there for hours trying to induce it and be unable to. So sometimes in these cases, you have to give things like epinephrine to sort of get the patient stimulated enough to induce a serious life-threatening arrhythmia. And once you've done that, then sometimes you've induced stuff that's very bad and actually very difficult to terminate. So when we used to do DFT testing routinely in patients, it was often very frightening when we would have a long QT patient, because you would try all the normal things to induce VT, which work very easily in most patients, and they would not in this type of patient. And then eventually, after giving a ton of epinephrine, you would finally do it and induce something terrible. And then oftentimes the shock wouldn't work, or you would need 4 shocks to stop it. And it was a really, it could be, you could go from having, watching paint dry on the wall to having a very frightening episode. So today, you notice we don't usually do DFT testing when we implant defibrillators. And the reason for that is because many studies have demonstrated that in most patients, if the sensing characteristics of the wire that's sensing are good, and if the pacing threshold is low, then the likelihood that you can rely reasonably heavily on the fact that the device will be successful. I think most studies have shown that if your R wave is over a certain size and the pacing impedance and the threshold are low enough, the chances of successful defibrillation with 2 shocks is like 98% or something like that. And so for that reason, we've sort of moved away from doing defibrillation threshold testing. I've never been 1,000% sure that's a good idea. I, in fact, wrote a paper early in my career in which we showed that about 10% of patients in that era needed an upgrade of their device based on defibrillation threshold testing. However, that was an era when devices had lower energy than the today. It used to be that when you would put a defibrillator in, you had to ask the representative for what they called a high energy device. So the low energy was like, I think it was maybe 25 joules, and the high energy was 35 or 40 joules. Today, all of the devices are high energy. So that probably has mitigated the risk of a failed shock in the setting of a good lead. And then implanting a pacemaker in somebody like this who has a normal heart rate really doesn't seem obvious to be of benefit, although there are some forms of rash with central clearing, some nonspecific joint pain, and the electrocardiogram shown here. What disease process will most appropriately explain these findings? Is it A, rheumatic fever, B, Lyme disease, C, Rocky Mountain spotted fever, D, Kawasaki disease, or E, systemic lupus erythematosus? I'm going to throw this question out to Dr. Sergey Bebia of New York City.
Good morning. So in this tracing, we see that the PR interval is different. Every single PR interval is different. So I think that this can be seen in B, Lyme disease.
That is correct. So let's just go through the choices. Rheumatic fever. Does rheumatic disease cause this?
Nope.
No. Now, what would be a setting of someone who has rheumatic fever and had it, who would get heart block? If you were going to make up a scenario that would make sense for a rheumatic patient to get heart block, how could you imagine a scenario? It would not,
somebody,
you're right, it would not naturally come from rheumatic. You do not get heart block from rheumatic disease in general, unless, yeah, you just don't. So, but could a sequelae of rheumatic disease cause heart block?
yeah, I guess. I'm just
Yeah,
thinking,
I mean, I'm being a little obtuse here. I'm sorry. What I meant was, you know, if you had bad enough mitral valve disease that didn't resolve and you had to have your mitral valve either repaired or replaced, you could get heart block from that. But that's a stupid question, so I apologize for that. All right.
Or
What
if
about
you had
Rocky?
like CCTGA and rheumatic fever.
Yes, that's correct. Or if you had been living in Cuba and been subject to the microwave attack from the Russians, then it's possible you would have had a heart block from that as well. Yes, the so-called attack from microwaves. Okay, Rocky Mountain spotted fever. Does that cause heart block?
no, I believe it doesn't.
No, I don't think it does either. What about Kawasaki disease?
Well, Kawasaki disease obviously can cause coronary artery aneurysms, but I haven't heard of any heart
Right.
block.
I mean, the only way I could imagine that is if you had it and you developed an obstruction, and which coronary would be the most likely coronary if it were obstructed, which would cause AV block?
Left coronary.
I think, actually, I think it's the right that most commonly supplies the AV node. And then finally, lupus. Can lupus cause heart block in a patient?
Lupus actually does, I think, cause some types of heart block. Yes, actually, that's possible.
I think that might be right. I'd have to really look that up, to be honest, but it wouldn't cause the other symptoms in this description, right?
Right.
Rash with the central clearing. It can cause a rash, right? I think it's classically a so-called malar rash, right? Like a butterfly rash on your face. Could cause non-specific joint pain. But
yeah, but that rash with central clearing.
Yeah, that is not right. That's not a lupus rash, right? Okay, so so if you had Lyme disease, if this patient came in like this, what would you do for them, Doctor?
I would treat the Lyme disease with antibiotics, doxycycline, And I will hope that this heart block resolves.
Would you, patient feels fine other than the joint pain, would you send them home on the antibiotics or would you watch them in the hospital?
We usually watch them for
Right.
a few days.
What are we watching them for, by the way?
We are watching them for any kind of heart-ridden problems that would put them.
Well, we know there's a heart rhythm problem.
Right, but whether this gets
Now,
worse
if you had
or
a
better.
crystal ball, I mean, if you had a crystal ball and you knew that the rate was going to stay the same as we're looking at now, you could send the patient home, right? You'd say, well, let's see if it gets better. But we don't keep people in the hospital to see if it gets better. We put people in the hospital to see if it gets worse, right? So it's possible that maybe awake, the patient's heart rate is this slow, but maybe asleep, the heart rate is 5, you know? So you would put them in the hospital because of the potential for it to get, for the ventricular rate to be so slow as to cause symptoms or worse. So, all right. A 14-year-old patient presents with a syncopal episode. Upon further investigation, you find out he'd been standing on a hot day in church and felt lightheaded before passing out. The event was witnessed and parents described brief seizure-like activity when he was syncopal. ECG and examination were normal. What is the next step? A, implantable loop recorder. B, 24-hour ambulatory monitoring. C, recommends increased fluid intake. D, electrophysiology study. And E, neurology referral. I'm going to ask, let's ask Dr. El Faturi. El Faturi, what do you think you do for this patient, sir?
Good morning.
Good morning.
I would recommend increasing the fluid intake.
That's exactly right. Yes, this is a patient. They're describing for you neurocardiogenic syncope. What do you make of the brief seizure-like activity?
I don't know.
Okay, that's always a fair answer. Basically, the point I'm trying to make is that when patients have neurocardiogenic syncope, they can seize briefly because they have hypoperfusion of their brain transiently. So seeing brief tonic-clonic type activity is not necessarily any more serious, assuming it stops after a few seconds. So usually when you achieve a supine position. Okay. What is the relationship of the conduction system in patient with an AV canal? A, posterior and superior to the VSD. B, posterior and inferior to the VSD. C, anterior and superior to the VSD. D, anterior and inferior to the VSD. E, on the left side of the heart. No, where is that on the left side of the heart? Anyway, I think we can fairly easily rule that last one out. But why don't we ask Dr. Barris what your thoughts are on VSD and AV canal conduction?
I believe the answer is B, posterior and inferior to the defect.
Yeah, I think you're right in that regard. That's the reason why there's a so-called counterclockwise looping with deep Q waves in one and L in people who have AV canal defects. Now, this is true for patients with standard AV canal who have 2 ventricles and 2 atria. For people with complex heterotaxy disease, it may not be there. And this is the rationale for those of you who may have listened to the podcast where I spoke with Elizabeth DeWitt about the fact that in Boston and some of the more complex VSDs, they're doing intraoperative mapping of the HIS because these general rules are good for questions in the boards and for heart surgery, but not for all patients. And sometimes they've identified that sometimes it isn't the patient's heart did not read the textbook. By the way, this is an important question for your boards. I would say there's a 50% chance it will be on your test. Okay. A 3-year-old boy has had 3 episodes of SVT in the past month. Apart from some apprehension and pallor, his condition is stable. The heart rate is 240 beats per minute. Tachycardia is terminated by 1 dose of adenosine IV. The ECG is obtained while the heart is in sinus rhythm. It's interesting to call it the heart and not the patient, but there you go. Which of the following drugs should be recommended to prevent a recurrence? A, verapamil. B, oral amiodarone to be taken only after tachycardia starts. C, digoxin. D, mexiletine, or E, propranolol. So let's go back to Dr. Bonsall of New York City and see what you think about this. So A, verapamil. What do you think about that? Well, first of all, which is the correct answer, do you believe?
Why not EP study? Why not EP study?
Not a choice. Well, let me ask you that question. Why not an EP study? First of all, have you seen Dr. Love or Dr. Pass do a lot of ablations in 3-year-olds?
No.
Not really, right? Like probably never, or maybe once. So why do we not normally do EP studies in kids?
Because kids are small. This kid is small. 3-year-old is small.
And what is being small? I mean, we catheterize newborns that are even smaller. Why is small a problem for an ablation in theory?
Because the structures are, I mean, obviously the heart is small and the structures are close by, so safe ablation is a problem.
Right. Now, you should know that there are data to suggest that you can do ablations in kids down to 18 months with almost exactly the same levels of safety and efficacy. But I think if you look at those paper, and there's a particular famous one written by Andy Blaufox when he worked with Phil Saul in South Carolina about 10, 15 years ago. Phil Saul's like one of the greatest electrophysiologists in the world. He's retired now. So maybe in Phil Saul's hands, it's very safe. But I think I'm not so certain that it's safe in everybody's hands. So we generally would not ablate that. So that's why that's not there. It wouldn't necessarily be the wrong answer, by the way. They couldn't put that answer there with the 5 choices they have because one of them is correct also. And then you'd have 2 correct answers. So since your preferred choice of ablation in your 3-year-old, because you are an aggressive cardiologist and you want all your patients just ablated right away, what is the other option for you? What's the right answer?
I'll do propranolol.
Okay, I hope I'm not waking you up there. Sounds like a little yawn. This question's a little too easy for you. Let's go through the choices. What about verapamil? Good idea, bad idea, and why would we do it or not do it?
I mean, we don't do calcium channel blocker because the calcium reserves are less in babies, but this is a 3-year-old. I don't know. I've never used it. I'm not very confident.
What do you think about this EKG? What is the patient's diagnosis, Purna?
WPW.
Okay, so what do you think about verapamil in a patient with WPW? You mentioned some made-up thing about calcium channel reserves or something like that. I don't know what that was, but what else is concerning about verapamil and WPW?
So you will block the conduction at AV node. So you will actually promote conduction through your accessory pathway.
And so what is the concern with verapamil chronically in WPW patients? Do you think verapamil would reduce the chances of having SVT if you had WPW?
No, it would not, because if you're blocking your AV node.
Well, actually, no, it would probably help, right? Because blocking the AV node makes it harder to have SVT, right? That's how propranolol, one of the ways in which propranolol works, right? Is it slows the AV node, maybe it lengthens the effective refractory period of the AV node, making it harder for PACs to conduct and induce tachycardia. So verapamil might actually be good at preventing SVT, but the reason we don't use it is because as you said, it can cause AV nodal slowing, and it could theoretically enhance accessory pathway conduction, meaning that in the setting of AFib, it could enhance the risk for sudden cardiac death. So verapamil is absolutely contraindicated in patients who have WPW, okay? The answer is never verapamil in someone who has WPW. So in this question, the important thing to be able to identify is that the patient has pre-excitation, which I think is pretty clear. And then they're asking you some questions. So they're not telling you explicitly that the child has WPW. So one thing the question is testing is, can you tell if the child has WPW? The other thing it's asking is, do you know anything about WPW? And we know that verapamil is absolutely contraindicated in WPW at any age, okay? We've talked at length in the past that IV verapamil, as you were alluding to, in very small infants is also absolutely contraindicated in everybody because of the tendency for it to cause a cardiovascular collapse and severe hypotension. But verapamil as a chronic agent or an IV agent would always be contraindicated in somebody who has WPW. Now, in the old days, before there was adenosine, if somebody came in an SVT and you didn't know they had WPW, it would not have been wrong to give verapamil to terminate the arrhythmia. But once you saw that the patient was pre-excited, you would stop verapamil and use something else. Okay, what about oral amiodarone to be taken only after tachycardia starts? Does that make any sense to you?
No.
Why is that? Why does it not make sense to you? You're correct.
I mean, if the patient is in SVT that is hard to break, you would rather do IV amiodarone. I've never seen oral amiodarone being taken as PRN, and
what's the half-life of amiodarone?
It's very long. It's
like 45 days. So what's the likelihood that you will achieve a level of amiodarone adequate to have any impact on SVT? Zero, right? So we would never recommend to a patient to take oral amiodarone for episodes of SVT. What about digoxin?
Same reason you cannot use in WPW.
Right. So similar to verapamil, it is absolutely contraindicated in WPW. The only exception to that is some cardiologists will use it in small infants less than a year of age with WPW and SVT. On the theory that AFib is very, very, very rare in that circumstance. I think in the present era, though, most cardiologists have generally moved away from the use of digoxin in small infants with WPW because there are many other agents. So it's just sort of one of those things where people feel, why would you take the risk? What about mexiletine?
I'm not sure about the mechanism there.
Okay, but what is mexiletine normally used for? So it's usually used for ventricular arrhythmias, right? Not for SVT. And it's not even a particularly robust antiarrhythmic agent for that. Really, it's sort of a drug that's looking for a disease. I think probably the most critical usage for it are certain patients with long QT type 3. Mexiletine is a sodium channel blocking agent. It can be effective for certain rare forms of long QT syndrome in shortening the QT interval, but as a general rule, you would never use that for SVT. So the answer is E, propranolol. One more today. All right. Which of the following statements most accurately describes the normal maturation of change in the ECG during the first week of birth? A, an increase in the size of the R wave in lead V1. B, a shift in the QRS frontal plane from greater than 135 to less than plus 50. C, a change in T wave polarity from positive to negative in lead V1. D, development of a Q wave in V1. Or E, shortening of the PR interval. We're going to ask our neonatal expert, Dr. Zawani, what do you think is the correct answer to the normal maturational change in the ECG in the first week of birth?
Hi, Dr. Pass. I think the correct answer is the answer C, change in the T wave polarity from positive to negative in lead V1. So that's actually sorry.
Go ahead. I apologize for interrupting. I'm sorry.
during the first week of life, usually the T wave inverts, and that's actually a sign of falling of pulmonary vascular resistance and pulmonary pressures, and that's usually we can track that from the EKG.
Yeah, that's certainly true. Yes. What do you think about a shift in the QRS axis from 135 to less than 50? Does that happen in the first week of life?
I think it's too early.
Right. And increase in the size of the R wave in V1. Does that happen normally?
No. What happens is that with time, the R wave starts decreasing progressively, and then you have a more S predominance with age in
Correct.
lead V1.
That's right. What about shortening of the PR interval? Does that happen naturally in the first week of life?
No, I think it's also too early.
Doesn't really happen at all.
Yeah.
Development of a Q wave in V1.
No, I don't think that happens.
Yeah, that doesn't happen, not to my knowledge. All right, I think that about sums it up for today. Are you guys enjoying these questions? Is this of value, you think?
Yes, thank you.
Yeah, very much. I think even the best part is the context and reviewing the wrong answers, because I think that's where a lot of the learning is.
Okay, great. So we'll finish up with some more next week. Thanks, guys. Good to see you all, and I'll see you in Sinai in just a little while. Take care.
Thank you, Dr. Press.
Thank you.